So we all know, just working in a radiology department, central venous lines are critical for the management of oncology patients, inpatients, and the critical care patients. They're used for administration of IV fluids, for nutrition, and for medications, and there are some medications you can give only by central lines, such as chemotherapy and pressors. They can also be used to monitor the patient's volume status and hemodynamics by measuring central venous pressure and pulmonary artery catheters, and there are specialized uses for catheters such as dialysis and phoresis catheters. There are four broad categories of central venous catheters. There are their peripherally inserted central catheters, the PICCs, that are usually inserted by a forearm vein. And then there are temporary central venous catheters, which are non-tunneled, and permanent central venous catheters, which are tunneled, and the implantable ports. So it's important when these catheters are put in that they be in the proper position to avoid complications and so that they function correctly. And the proper position of a central venous catheter is in the SVC or at the cava atrial junction. And in the literature, there have been a number of ways described to localize the cava atrial junction on radiography, and there's not universal agreement as to which is the best. But in this article in Journal of Thoracic Imaging, the authors proposed that where the bronchus intermedius crosses the right heart border seemed to be the most accurate. However, it was not accurate in everybody, and it's not a precise anatomic location because things vary with technique, they vary with patient anatomy, but that seemed to be a reasonable approximation of where the cava atrial junction is. Other ways I've seen people do it is identify the takeoff of the left upper lobe bronchus, draw a line over, go down 2 centimeters, puts you in about the same place. Some people like to measure vertebral bodies below the carina. But however you do it, it's important to find a way that's consistent at the institution and a way that reasonably approximates the cava atrial junction, because the catheters in general are not supposed to be in the right atrium due to a theoretical risk of right atrial perforation and tamponade. There are a few rare case reports. Catheters that are in the right atrium can also lead to arrhythmias, and if it gets in the region of the tricuspid valves, you can get vegetations. In certain circumstances, catheters may intentionally be placed into the upper right atrium, for example, dialysis catheters, to try to decrease the incidence of fibrin sheath, but in general, that should be viewed with caution. So this is a venogram image, and I really like this image to discuss the venous anatomy because it shows the venous anatomy relative to the bones of the thorax, which is what we see on radiography. The axillary vein becomes a subclavian vein at the lateral margin of the lateral margin of the first rib. The subclavian vein extends centrally where it joins with the internal jugular vein, and then the innominate veins join to form the superior vena cava. I want us to notice two things about this diagram in the venous anatomy. Notice that the subclavian vein is located immediately posterior to the clavicle. Veins do not usually extend significantly above the clavicle. We're going to come back to that. The other thing on this diagram that I like is that it shows that the right innominate vein is usually very closely associated with the medial aspect of the right first rib. This is pretty consistent. The other thing this diagram shows is it shows about where the confluence of the innominate veins is relative to the ribs, and it's usually in the upper aspect of the right first intercostal space. Some patients have a confluence which is actually lower down towards the right the tracheobronchial angle. But in general, it's usually the upper aspect of the right first intercostal space. So this is a diagram from AJR by Dr. Godwin, and it shows beautifully the veins of the thorax. So how often do malpositions occur? It's about a third of the time. We've already talked about right atrial malpositions. Then there are venous and there are non-venous malpositions. Of the venous malpositions, one of the more common that we see with PICC lines and subclavian catheters is that the catheter gets into the ipsilateral right internal jugular vein, and when the catheter is advanced, it can extend up into the neck. It's pretty common. Similarly, a catheter can extend centrally to the confluence of the innominate veins, can cannulate the contralateral innominate vein, and when it's advanced, it can extend peripherally into the contralateral innominate vein. And then there are a number of smaller veins that catheters can get into. The internal mammary or internal thoracic veins insert to the innominate veins bilaterally, and catheters can hook into these. There's a catheter that hooks around the aortic arch. This is the left superior intercostal vein, and this is the vein referred to as the aortic nipple when it's visualized on chest radiography. This inserts to the inferior aspect of the innominate vein, and left-sided catheters can hook into this. The azygos vein ascends in the mediastinum where it turns to the right over the right main bronchus, and it inserts into the posterior aspect of the SVC, and catheters that are inserted can hook into the azygos arch. And there are two veins, the left and the right pericardiophrenetic vein, and these insert to the innominate veins, Catheters can theoretically get into these, but these are usually very small, so it is pretty rare. Non-venous malpositions include arterial catheters, and these are identified by catheters that do not follow venous anatomy, but rather follow arterial anatomy, and we'll look at that. And then catheters that follow neither venous nor arterial anatomy may be extravascular and are often associated with a mediastinal hematoma. So when a clinician puts in a catheter, these are really the things they want to know. Number one, is the catheter in the right position? Did I give the patient a pneumothorax? And if it's a difficult stick, or if the patient has a coagulopathy, did the patient get a bleeding complication such as a hematoma? These are two of the more common malpositions we see. Here's a right-sided central venous catheter. This one extends all the way to the inferior right atrium. This needs to come back to the caveatrial junction. Here's one of those catheters that has hooked into the ipsilateral internal jugular vein and goes up into the neck. Here's a catheter, right subclavian, goes into the right innominate vein, confluence of innominate veins, and extends peripherally into the left innominate vein. This one's a little tougher. This one comes down and extends down the left, and it overlies the descending aorta. I can think of four possibilities for this. Number one, could this catheter be in a small thoracic vein? Definitely could, and I think of the veins we just discussed, I like the left internal mammary vein the best. Could this patient have anomalous venous anatomy, like a left-sided SVC? Definitely could. I think if we were going to say this, though, we need to have prior imaging showing this patient actually does have a left-sided SVC, or you need to do a CT or a venogram to prove it. Could this catheter be arterial? Yes, it could, and I think we need to make sure that it's not. It's overlying the aorta. The other possibility is the internal mammary artery. Could this catheter be extravascular? It's very regular looking. There's no hematoma, so I don't like that one as much. So this patient with the left-sided catheter got a lateral view, and you can see it's running retrosternally. This is in an internal mammary vessel, probably the internal mammary vein, and this was taken out. Here's another catheter, similar look. This one does not overlie the descending aorta, however. You look in the file, this patient has a known left-sided SVC. Here's a catheter placed from the left, and there's a curve lateral to the aortic arch. Anatomically, this is exactly where the left superior intercostal vein is, and it inserts to the inferior aspect of the left innominate vein. You have to be careful when you see these. This is in the left superior intercostal vein, but I've seen CTs done, and actually this can perforate the vein, and I've seen these wind up out in the mediastinal fat after it's perforated the left superior intercostal vein. Here's the catheter inserted from the left, and this is anatomically the azygos vein, and the azygos vein ascends in the mediastinum up over the right main bronchus. This catheter is in the azygos arch. Here's a catheter running along the left heart border. This is in the left pericardiphrenic vein. Here's a catheter that if we see this should bother us a lot. So this catheter extends to the left. It actually ascends away from the right first rib and crosses midline. This is an arterial catheter. Remember that we said that the right innominate vein is usually very closely associated with the right first rib. This actually ascends away from the right first rib, crosses midline, and overlies the aortic arch. This is an arterial catheter. Here's a left-sided arterial catheter. Remember we said the left subclavian vein does not usually go significantly above the clavicle, and this one does. This is in an artery. And this descends right where the left subclavian artery originates from the aortic arch. This could either be in the ascending or the descending aorta. It's an arterial catheter. Here's another one. This one's a little trickier. This one is sort of behaving in the direction of a venous catheter, but its location is a problem. Remember we said the veins are usually right behind the clavicle, and it goes just medial to the right first rib. Look how high this goes above the clavicle. Look how far this is from the first rib. This is the path of an artery, not a vein. And this is actually the right brachiocephalic artery here. It becomes the subclavian artery here. And if you think of what vessel originates here from the subclavian artery, it's the vertebral artery. And unfortunately, this patient had multiple posterior circulation strokes from that arterial catheter. Here's another arterial catheter. Here, the port actually identifies nicely for us the path of the right innominate vein. It's just medial to the right first rib. This catheter is bending away from the first rib, crosses midline, and it's extending towards the aortic arch. This is in the right brachiocephalic artery. So any catheters that are turning away from that right first rib, they usually catch my attention, and I'm concerned it's not venous. And this patient, unfortunately, also had a right-sided stroke from this catheter. Here's a catheter that's not behaving by any venous or arterial anatomy. It's just hanging out in the mediastinum. It overlies the inferior right hilum, may even be in the pleural space. There's a right paratracheal hematoma. This is an extravascular catheter. So we mentioned malposition. We've gone through many, and I'm not going to spend a lot of time on pneumothorax other than to show this example of a left subclavian central venous catheter with an apical pneumothorax, and a beautiful example of a deep sulcus sign, which is the classic manifestation of a pneumothorax in a supine patient. This is an example of bleeding complication. This patient had a introducer sheath placed. The tip is in the region of the SVC. This was a very difficult placement. It took multiple attempts to get this catheter in. A few hours later, the patient developed chest pain. Hematocrit was dropping, and you can see this mass in the right mediastinum that's developed in the interim. This was a mediastinal hematoma from a lacerated right brachiocephalic vein, and this patient had to go to the OR to have this repaired. Here's a relative malposition that I mentioned. Ideally, when a left-sided catheter is put in, it would go into the left innominate vein, turn inferior, and then it would wind up parallel to the lateral margin of the SVC, ideally. But sometimes this is what happens. The catheter gets put in, and it winds up perpendicular to and contacting the lateral wall of the SVC. This was actually described in AJR, and the authors described that when this happens, if there's a general curve of the catheter, that can be a sign of impending catheter perforation of the SVC. So when I see this, I usually call up the clinician. I recommend that they pull this back 1 centimeter, 2 centimeters, just to get this away from the lateral wall to avoid this complication entirely. So rare complications of central venous catheters include catheter fragmentation, resulting in catheter embolus, kinking or compression of catheters. Air embolism is rare. And in addition to pneumothorax, additional pleural complications include hemothorax, especially if an artery was punctured and has communication with the pleural space. Central lines placed from the left, if the puncture is deep enough and injures the thoracic duct, could result in a chylothorax. And very rarely, if a catheter is placed in the pleural space, can result in an infusothorax. So this is a patient who had a PICC line in place and went to bed, and when he woke up in the morning, he couldn't find his PICC line, but he found the outside part somewhere else in the bed, and then he came in to get this x-ray, and you can see that the PICC line is embolized to both the right and the left pulmonary arteries. So this is a PICC line catheter embolus. This is a patient who has a fracture of a portocath between the left first rib and the clavicle. This is a typical location due to the repetitive trauma of arm motion. There can be repetitive compression of the catheter and can result in fracture and catheter embolus, and you can see here the catheter is in the right heart. This is the so-called pinch-off syndrome, where it's pinched off between the clavicle and the first rib. This is a catheter fragment, and it's pretty scary, actually. We've got a lot of things going on here. We have an ICD device in place. It looks like a pulmonary artery catheter, except if you look, it doesn't actually connect to the introducer sheath. And this pulmonary artery catheter had fractured in the right atrium, and this is a catheter fragment in the right atrium, the right ventricle, and the pulmonary arteries. This was removed by a snare, and this was taken out. Sometimes catheters can kink. This is a catheter that has kinked, probably where the internal jugular vein is inserting. This often happens at bends of catheters or sometimes at the skin insertion site, and this may be a reason a catheter is having difficulty infusing or drawing blood from the catheter. Air embolus is usually not a problem if it's small. If it's large, there have been reports that you could see air in the pulmonary arteries or in the heart, but it would have to be a lot of air. In patients who have repeated medium amounts of air, such as this patient, you could get a pulmonary edema pattern. This patient had an introducer sheath put in, and there was a malfunctioning stopcock. And every time the patient took a deep inspiration, there was a sucking sound. And this patient had multiple medium-sized air embolus, and it resulted in a pulmonary edema pattern. He was very, very short of breath. So the catheter was replaced out, had a functioning stopcock. The patient was put in the left decubitus position to get the air in the right atrium away from the pulmonary outflow tract. He was given high-flow O2, and the next day looked much better.